I will cover HIV. This is the first part of HIV, in which I'll cover the general structure of HIV and the diagnosis, the opportunistic infections, and the treatment. And in the next video, I will also talk about the very high yield questions related to HIV. So let's start with the structure of HIV. So human immunodeficiency virus, it is composed of certain proteins, all right, and these proteins come from various genes. So we will talk about those very specific genes which leads to the formation of this HIV virus. So HIV virus is an enveloped virus. It is acquired through budding from the host cell plasma membrane. And this envelope virus consists of a single-stranded positive sense RNA retrovirus. And the genes which make up the HIV virus are three main genes. Those are ONV genes, then it is the GAG gene and POL gene. So the ONV gene leads to the production of GP160. GP160 cleaves into GP120 and GP41. So GP120 is the outer one. This one, G120, attaches to the patient's CD4 T cells, while the GP41 leads to the fusion and entry into the human cell. So this is how it attaches. So imagine that this is the CD4 cell. The CD4 has either CCR5 or CXCR4 co-receptor binding. So this is on the CD4 cell. So the HIV virus attaches to the CD4 via the GP120, and with the help of GP41, it leads to fusion and entry into the human cell. So the GP120 can attach either to CCR5 or it can attach to CXCR4 of the CD4 cell. So when the virus binds the CD4 cell as a co-receptor, either CCR5 on macrophage, it leads to early infection. So when the virus attaches to the CCR5 of the CD4 cell on the macrophage, it leads to early infection. If CXCR4 on the T cell, that results in a late infection. These two are very high yield points. Homozygous CCR5 mutations leads to immunity. All right, some people are immune to HIV because of homozygous CCR5 mutation. A heterozygous CCR5 mutation results in a slower course of HIV. Okay. Next is the GAG gene. The GAG gene leads to the production of P24 and P17. If you look into this picture, P24 and P24 forms the capsid protein, while the P17 forms the matrix protein, the outer one, the matrix protein. Okay, then the POL gene leads to the production of reverse transcriptase and protease integrase. Now these two are important for the replication of the virus. Okay, now next we will talk about the opportunistic infections that because of a low CD4 count. Okay, so the three main categories: less than 500, less than 200, and less than 100 CD4 count. By default, any patient who have a CD4 count less than 500 does not need any prophylactic treatment. A patient who has CD4 count less than 200 will need trimethoprim sulfamethoxazole, and patients who have a CD4 count less than 100 will need azithromycin and trimethoprim sulfamethoxazole as a prophylaxis. Okay, now let's see what are the bugs that causes those opportunistic infections. A count of less than 500 can result in Candida albicans, which is just confined to the oral thrush, Epstein-Barr virus, HHV8, and HPV viruses. Now, Candida albicans and Epstein-Barr viruses, these cause similar oral lesions. Candida albicans can cause oral thrush that is scrapable, all right, versus Epstein-Barr virus cause oral hairy leukoplakia, which is not scrapable. Okay, then HHV8 causes Kaposi sarcoma, which are palpable non-pruritic lesions that is brown, pink to violaceous in color. Then HPV causes squamous cell carcinoma of the anus. Okay, Then a CD4 count less than 200 causes histoplasma capsulatum, which results in a non-specific features: fever, night sweats, chills, and weight loss, nausea, vomiting, dyspnea. Macrophage contains oval yeast cells. Now that is predominantly seen in specific areas. All right. JC virus causes reactivation, um, results in a progressive multifocal leukoencephalopathy, demyelinating disease of the central nervous system. So actually, there are two drugs from the immunology section of the first aid. If you can recall that the um, rituximab and natalizumab are the two drugs which causes JC virus reactivation. Natalizumab is a drug for the treatment of multiple sclerosis and Crohn's disease. So those two drugs and rituximab can also can cause JC virus reactivation. Just a feedback. And then a pneumocystis jirovecii. These causes pneumonia, ground glass opacities on the chest radiograph. So for pneumocystis, uh, trimethoprim sulfamethoxazole is needed. And a lot of patients are allergic to TMP-SMX because of the sulfa component. And so in that case, you may use dapsone, atovaquone, or pentamidine. Cryptosporidium parvum causes watery diarrhea. These are acid-fast oocytes found in stools. Treatment for that is nitazoxanide. A CD4 count of less than 100 causes a variety of infections. First is a fungal infection by Aspergillus fumigatus, which can result in hemoptysis and pleuritic chest pain. Bortonella hanseatic, which causes bacillary angiomatosis. Candida albicans can cause esophagitis. White plaques may appear on the endoscopy. CMV causes retinitis, esophagitis, colitis, pneumonitis, encephalitis, lineal ulcers on the endoscope. Fundoscopy may show cotton wool spots, and intranuclear inclusion bodies, I, this is the buzzword for the identification of CMV. Cryptosporidium again can cause watery diarrhea in patients less than 200 CD4 count. EBV causes B cell lymphoma, central nervous system lymphomas. Now, these two um, um, need to be differentiated from Toxoplasma gondii, which also causes ring enhancing brain abscesses. Also, the EBV causes ring enhancing lesion on the brain MRI. So the way to differentiate between EBV and Toxoplasma is that Toxoplasma are multiple ring enhancing lesions versus ABV is a single um, or a lymphoma or a ring enhancing lesion on the MRI. All right. Then um, so for Toxoplasma gondii, you need to treat with 3-MPSMX. If contraindicated, you may use dapsone, pyrimethamine along with leucovorin. And in the presence of the ring-enhancing lesions, treat with pyrimethamine. This is a very high yield point. So MAC, or Mycobacterium avium intercellulare, is another disease caused by MAC. It causes a non-specific findings like fever, night sweats, weight loss, lymphadenitis. The treatment here is azathioprine. So any patient, by default, coming with a CD4 count less than 100, you want to prevent these infections, and so you want to start with azathioprine TMP-SMX by default to any patients depending on the CD4 count. So these are the opportunistic infection caused by CD4 T cell count. Based on CD4 T cell count, now we will go and study the diagnosis of HIV. So diagnosis of HIV, you always begin with HIV serology, which is the best initial test which detects both HIV-1 and HIV-2 antibodies and HIV P24 antigen. Let's go back. This is the HIV P24, which codes for the capsid protein. All right, so this is the very specific identity of the HIV virus. So you want to do the HIV P24 antigen and HIV-1 and 2 antibodies. That's called a combination of HIV-1 and 2 immunoassay. It's the best initial test because it's both specific and sensitive. So this test is recommended for at least once for all patients aged 15 to 65, regardless of risk factors. men who have sex with men, pregnant women, IV drug users, patients who engage in unprotected sex, and those diagnosed with another sexually transmitted disease. Now, if this test turns out to be negative, then the patient does not have HIV. If this turns out to be positive, then you need to perform some other test to confirm your diagnosis. And that includes HIV 1 and 2 antibody differentiation. So patients might be infected by HIV 1 or HIV 2 or by both. So you want to differentiate between the antibody, and so you do that kind of immunoassay. Or sometimes, if this test is negative, then you may do a viral load, or you may do a something called the nucleic acid test. Okay, we will come to it in a while. Then, when you do a viral load, why is it needed? It's needed because of three main reasons. You want to record the amount of virus the patient has. Second, you want to see the response of your treatment. Third, in babies, why do you check the viral load and not the antibody test in the babies? Because babies will have the maternally transferred antibody, and this gives a false positive result. And therefore, you want to do a viral load for patients, babies patients who are positive for HIV, and to test their babies. Then CD4 T cell count and percentage is again important to determine the need for prophylactic medications against the opportunistic infection and to record the response to antiviral therapy. HIV genotyping is needed to determine the HIV mutation for the sake of drug resistance. Okay? Now, so the first step is always the HIV 1 and 2 antibodies and P24 antigen combination immunoassay. If it is negative, you're not infected. If it is positive, then you want to confirm or differentiate between HIV 1 and 2. If HIV 1 is positive and HIV 2, then this means you are infected by HIV 1 antibody. If H2 is positive, then you're infected by HIV 2 antibodies, infected by HIV 2 virus. If both positive, you have both viruses. Now let's say both are negative or intermediate, then you would do an HIV-1 nucleic acid amplification test. If that is positive, then that is accurate and you have the infection. If that is negative, then no infection. This is how the HIV is diagnosed.